Good morning, everybody. Today we're going to go over the growth and development for the adults. If you'll bear with me, I'll get this PowerPoint up here. Okay. I have given you some handouts or included some handouts in this. One is a brief article on each one of the growth and development theories on the and the other couple are some fast facts that I've given you for the developmental theories on the adults. One is on each one of them stages, and I hope this will be handy for you, not only for the test but when you get into the clinical setting, because you will have to give examples of your growth and development on each one of your patients. And the other one is on the same thing. So hopefully they will help you as we go through this, as you study for your tests, plus as you go through your clinicals. First, we're going to talk about the theories before we get into the other stuff. Okay? And the first one we're going to talk about is Erikson. Miss Candler has gone over the first part of Erikson's with you in the child, and I'm just going to hit on stages 6, 7, and 8, which are the adult issues. As you probably learned from her, he held with the belief that the personality develops in a series of stages. His theory describes the impact of social experiences on the whole lifespan. He begins with childhood, and he felt that it was particularly important during adolescence and continues throughout your life, this social impact. He also felt that people experience a conflict that serves as a turning point in the development, and that these conflicts are centered on either developing a psychological quality or failing to develop that quality. Okay, so stage 6 is your intimacy versus isolation. It covers a period of early adulthood when the people are exploring their personal relationships. People develop close, committed relationships with other people, and if they're successful in their relationships, they are committed and secure. He felt that a strong sense of personal identity was important for developing these intimate relationships. If the person has a poor sense of personal identity, they're going to more than likely suffer emotional isolation, loneliness, and depression. Success in this step will result in the virtue of love, which is marked by the ability to form lasting and meaningful relationships with others. And then stage 7 is a stage where the person continues to build on their lives. They focus on the careers and family. Those that are successful with this feel that they are contributing to the world, and they're active in their home and their community. And those that fail to do this feel like they're non-productive and uninvolved in the world. The ones that are successful are going to achieve a virtue of care. They're proud of their accomplishments. They love watching their children grow into adults, and they develop a sense of unity with their life partners. Now, stage 8 is integrity versus despair. And during this, it occurs in old age and is focused on reflecting back on their life. Those who are unsuccessful feel that their life has been wasted, and they're going to have experiences of many regrets. Excuse me. They're going to be left with a feeling of bitterness and despair. And those who accomplish this step, they're going to feel proud of their accomplishments. They're going to have a sense of integrity. They're going to look back with very few regrets, and they're going to have a general feeling of satisfaction. And in this stage, the virtue that Erikson said they attain is wisdom. Now, the second theorist we're going to go over is Haverhurst. Okay? Haverhurst believed that development is continuous throughout the entire lifespan, and that the individual moves from one stage to the next by means of successful resolution of problems or performance of developmental tasks. The task that these developmental tasks hinge on the person's culture that they belong to. Successful completion earns them community and social approval, which provides a foundation to accomplish further tasks during their development. If he's unhappy, whereas if he doesn't complete these tasks, he's going to be unhappy, and society's not going to give their approval. And then they are going to go on and have difficulty facing the task if he's not been successful. Haverhurst proposed a biopsychosocial model for development where each stage is influenced by the individual's biology, biopsychosocial, which is their maturation or their genetics. The psycho part of it is their values and their goals. The sociology part is their culture that they belong to. He believed the biological characteristics develop similarly no matter what culture they are from, and these are things like walking, while other parts of their biological psychosocial, like talking and coping mechanisms, are influenced by their culture. The psychological factors that emerge from maturing are values and goals, and they are another source of developmental tasks like self-concept, relationships with your peers, adjusting to your retirement, loss of your loved ones, those types of things. Other tasks that arise for unique cultures in their society, like preparing for occupations, achieving gender appropriate roles, and becoming responsible citizens, do involve quite a bit of your culture. Okay? In early adulthood, Haverhurst felt that they chose a partner, they established their family, manage a home, and establish a career. Then they move on to a middle age, which is your 36 to 60s, and they maintain an economic standard of living. They perform civic and social responsibilities. They relate to their spouse as a person and adjust to psychological changes. And then they move on to later maturity, which is your patients over 60 years of age. Things you should be seeing with them are adjusting to deteriorating health and physical strength, and then their adjustments to retirement, meeting social and civic obligations, and adjustment to death and loss of their spouses. In Levinson, and he is our third and final adult theorist that we're going to go through, he suggested that within each era there is a unique set of tasks that cause a person to attempt to build or to modify their life structures. These errors last 25 years, and a transition through them can last anywhere from 3 to 6 years to complete. And he felt that these transitions were a time of upheaval because of the changes that are going on characteristic in the life. One thing that is seen throughout his theory in all stages is the existence of a dream, and this dream is a mental picture that you have of your ideal life. And you are constantly going to be going back and looking at this dream and revisiting it and comparing it to the reality that you are living. Also seen throughout his theory is the idea of individualization, or becoming an integrated person separate from their parents and others. Okay? So, early adulthood transition is focused on ending that pre adulthood time in your life from 17 to 22 and beginning the early adulthood. You're going to look and question the places, your place in the world, your relationships. Going to try to cut those ties from their parents in other groups that they've had during their adolescence. And they're going to begin to try on adult roles and assume adult identities. And that will transition them into entering the adult world at 22 to 28 years of age. This is where they're going to start making choices about love and occupation, friends, and their values. Okay? And at the end of the entering the adult world, they're going to go through age 30, the transition, which is 28 to 33 years of age. And this is changing their life structures, which are more moderate to severe in stress. It's continuing to build on that life as an adult. And when they get through the transition, then they end up in the settling down period, which is where they find their niche in society. They establish a family. They establish their career. They have children. They're beginning to think and behave like parents. And they realize that they have very demanding roles in life. This leads them to the midlife transition, where their life structure they start to question it. They question the meaning of their life, the values in their life, and the direction that their life is taking. In other words, as the old saying goes, a midlife crisis. Okay? Younger adults that they interact with will see them more as a parent instead of a brother, and this can be really difficult for some men especially. Okay, awareness of death is present in this age range, and they are beginning to realize how very short life really is. They're starting on beginning to want to leave their legacy. Okay, which pushes them into entering middle adulthood, where choices are made and a new life structure is formed. They commit new tasks and reflect on the achievements that they have had and the regrets that they've had. Then we're going to go into late adulthood, which is a reflection on their life achievements and their regrets involving their self, their others, and God. Okay? And that's our three theorists. Now we're going to jump over into our theory book, and we're going to work on chapter 2 here. I want to give you some of the highlights of it. This is common health problems in the older adults. Most patients in the acute care are older than 65 and discharged to home health services. So nurses and healthcare professionals, they need to know about the special needs of these older adults in order to take care of them in a variety of settings. You're going to see here the subgroups of late adulthood. You've got your young old, your middle old, your old, and the elite old. The fastest growing subgroup is the old, or the advanced older adult population. Frail older adults are at high risk for adverse outcomes. Frailty results from unintentional weight loss, weakness, and exhaustion, and slowed physical activities, like they're walking. Most older adults experience at least one hospitalization in their lifetime and have a greater chance of experiencing an admission to a long-term care facility for rehab or complex care after surgery. Another thing that you will see is the number of homeless people over the age of 60 is growing. A lot of this is due in part to inability to pay for their housing. It might be social and family problems, breakups of families, A lot of the homeless that are out there have mental and behavioral health disorders or chronic health problems. And you'll also see that a growing number of this population are our veterans. Okay, common health issues and concerns. I'm giving you a list here. Health issues can affect the ability to perform their ADLs and participate in their social roles. Failure of these in these areas can have a negative effect on the morale and the life satisfaction of your patients. When they lose these abilities, the older adult can often feel empty and worthless. The loss of their autonomy due to these physical and mental changes in aging can be very painful events for these patients. As nurses, we're responsible for supporting their self-esteem and their feelings of independence. We need to make sure that we enable them to maintain as much control as possible over their life while we are caring for them. Encourage them to participate in that decision-making ability instead of just going out and making decisions for our patient. We're not in that big a hurry. And we need to encourage them to perform tasks as much as possible, or as much as their illness is going to allow them to do, and then step in to take over. And as you see here on the list, you've got decreased nutrition, hydration, decreased mobility. All of these we're going to go into step by step, okay, or an item at a time. Now, you also need to teach your patients about health protecting behaviors. You need to assess these and make sure that they're being followed. One of your preventions is your vaccinations. They should have influenza vaccination every year, the pneumococcal every 5 years or more often if their health status requires it. That will be up to the doctor to determine, and then they do need tetanus boosters every 10 years. Okay? You need to assess whether the patient wears seatbelts or not. I know a lot of you guys are younger, but I'm getting up there to older adult, and I can tell you that I can remember when cars did not have seatbelts in them. Okay? And so anyone older than myself, which is, I'm 55, anybody older than that, you know, you're going to need to assess if they're using those seatbelts or not. They need to have moderate alcohol use. That alcohol use, according to your book, is 1 drink a day or 7 drinks per week. Okay, no smoking. You want to encourage them to stop smoking. They need to have smoke detectors and sprinklers in their home. Sprinklers are not very frequent in homes, but you know, if they're living in a nursing home or some kind of assisted living center, then they should have sprinklers in them. Herbals and supplements is prescribed. You need to make sure that they are aware that they need to disclose whatever they're taking to their doctor and make sure that he is aware because of interactions with drugs. They need a hazard-free environment, like no scatter rugs. Watch the wax on the floors if they have wood floors or tile floors, because wax can cause glare, and also they can cause it to be slick. Yeah, they need to maintain adequate lighting on stairs, such as a 60-watt bulb or higher. Okay. They need to make sure they keep their clutter picked up. So some of these common health issues that we're going to go over, like I said, we're going to go over these and we're going to do them one at a time. Causes for malnutrition. I've given you a list here of some of the causes. These patients that are older adults, they need to increase their calcium, vitamin D, vitamin C, and vitamin A because of the aging changes that are going on in our body. The ability to store these, use them, and to absorb these substances is decreased. If your patient has a sedentary lifestyle, they may need to decrease their caloric intake to maintain that ideal body weight. Often they have a diminished sense of smell and taste. So their desire for food may be decreased. Also, with this diminished sense, they tend to sweeten and salt their food more because they cannot taste it anymore. So you need to teach your patients to substitute some herbs and spices to season their food. Like I said before, you need to teach the patient that all over-the-counters and an overuse of over-the-counter drugs and supplements can decrease their appetite. It can affect their food tolerance and absorption, and it can cause constipation. The older adult needs to consume 35 to 50 grams of fiber in a day and drink at least 2 liters a day unless it's medically contraindicated. Okay? If a patient is having difficulty with constipation, they might also need to take a colon cocktail, which would be 1 to 2 tablespoons of equal parts of prune juice, apple juice, and psyllium a day in their diet. Okay? You need to also contemplate why they might be having difficulty with nutrition. The lack of transportation or the inability to carry heavy groceries can prevent these older people from taking advantage of food programs or going to the grocery store and getting the foods that they need. Others might be too proud to ask for help. A large amount of older adults live alone, and it can cause them to lose the incentive to prepare food or to eat food. These patients are also at risk for dehydration because of their decreased body water content that comes with aging. You need to teach these patients that fluid restrictions can make them more susceptible to dehydration and electrolyte imbalance, especially their sodium and their potassium, and that those can cause some serious problems, like heart arrhythmias. Remind them to avoid excessive caffeine and alcohol, because excessive caffeine and alcohol can also cause dehydration as well. Okay? Now let's talk about generic failure to thrive. It's a complex syndrome. A large amount of the older adults live alone, and this causes them to lose the incentive to prepare food and eat food, like I was telling you. Geriatric failure to thrive is a very complex syndrome of undernutrition, impaired physical functioning, depression, and cognitive impairment. And do not just take it for granted just because they're not eating and they are losing weight that it is failure to thrive. This is pretty much, almost has to be diagnosed by the physician. Okay? Exercise, physical activities can help keep their body in shape and maintain the level of function. It gives the patient the advantage of decreasing their risk for falls and depression, while they are increasing their muscle strength, their mobility, their sleep, their sense of well-being, and their self-esteem. It can also help improve their longevity. Mobility also reduces or maintains their weight and reduces the risk of diseases like diabetes, heart disease, and dementia. If the patient is homebound, they can focus on their functional fitness, like performing their ADLs. Walking improves strength and endurance and gives the patient the advantage of weight bearing. Swimming is another good exercise, but it does not give them this weight bearing advantage. Okay, you need to teach your patient to start slowly and gradually, and if they've been sedentary, they need to start exercising under the direction of their doctor. Another issue they have is stress and loss. Stress can speed up the aging process and lead to disease and decrease the older adult's ability to respond to changes in their environment. How each patient reacts to stress and loss is going to depend on their coping skills and their support networks. Their poor health and their social problems can lead to stress overload, which can cause illness and premature death. How a person adapts in old age is going to depend on their personality and their coping strategies, like I said. Their nature of friendships is very important to them. To this, if they have close, intimate, stable relationships and they confide in these others, they are more able to cope with stress and loss. Most older adults are relatively healthy and they live in their own home, which is very good, because older adults have a difficult time adjusting to major changes when compared to the younger and the middle adults, such as, like being admitted to a nursing home or going to a rehab, or even moving in with adult children. Okay, relocation stress syndrome is a physical and emotional distress that occurs after the person moves from one setting to another, like home to hospital, or hospital to nursing home, or home to nursing home. This can be decreased somewhat by allowing the patient to participate in deciding how the space is going to be arranged. Okay, so you want to let them design their own room layout, what they're going to have in their room, and a lot of this can help offset feelings of powerlessness that this patient is going to have when they're relocated. Okay, accidents. Most occur in the home, so make your patients aware of the need for safety precautions. Some patients develop a fear of falling, which is called fallophobia, and it will lead them to avoid leaving their house and familiar surroundings. You need to teach your patient to apply some safeguards to their houses, like handrails, slip-proof pads underneath their rugs if they have area rugs. Like I said before, adequate lighting, removing the clutter, grab bars and non-skid bath mats. You need to teach the patients to be aware of changes in their sensory perception and their mobility, and that these can create challenges for the patient in any environment, such as presbyopia. Okay, encourage the patient to look down when they're walking, and remind them that they need to have frequent eye exams and update their glasses as needed. You also want them to reduce or realize that they will have a reduced sense of touch, which can alter their sense of body orientation and decrease their reaction time. You want to encourage the patient to use any assistive devices they might have, like glasses, hearing aids, and ambulatory aids. Okay. Motor vehicle crashes are the most common cause of injury-related death in your 65 to 74-year-olds. As these patients age, like I said just a moment ago, their reaction time and their ability to multitask is going to decrease. Okay. The physician and healthcare providers, we play as their physicians and healthcare providers, we play a major role in identifying driver safety issues. But a lot of times you will see that doctors and nurses are reluctant to do this because of disrupting the patient's independence. We're all about, advocating for their independence, but we don't want to disrupt that. Ways that you can help them with their driving safety without disrupting their independence is recommending that they take a driver's refresher course, and suggesting to them that they don't drive in those high-risk conditions like wet or icy roads, or at night if they're having difficulty seeing. Okay? Or like stay away from busy intersections if they live in a city-type atmosphere, such as Little Rock or Jonesboro, to take the side roads instead of taking the interstate. Okay? Assessing risk factors and preventing falls. You need to assess a history for a fall, determine their age, what type of illnesses they have. As you can see, this list that all are indications or risk factors for falls that you need to assess in your patients as they come into the hospital and every day. Okay? Gait and postural stability, their drug assessment, and what type of drugs are they on, how are they interacting with each other, are they incontinent, communication and vision impairments, do they have glasses, are they hard of hearing, can they hear, machinery coming along behind them in the hallways and stuff like this. Are they abusive of alcohol or any other substances, like narcotics, street drugs, this type of thing. You also need to assess their reactions around shift change and mealtime in the hospital and the nursing home, because this is when they are in the room and most vulnerable. And this is when the staff is busy trying to get food out and trying to get the other staff situated on the patients that are on that hallway. A lot of times, especially in, say, like White River, now for a shift change they do bedside reporting, so this is cut down on some of the incidents of problems during shift change, but not all of them, because as you're in one room, it might be across the hallway or 5 rooms down from where you're giving report that the patient is up and moving around. Okay? Next, we're going to talk about drugs. What's the difference between polymedicine and polypharmacy? Okay? Polymedicine uses many drugs to treat multiple problems, and polypharmacy uses multiple drugs and high doses for too long a period of time to treat a disease. Okay? Older adults will also use multiple over-the-counters without consulting their healthcare providers, so you need to instruct them or the family members to bring in all of their medications for you to visualize, okay? All of this is going to put them at a greater risk for adverse drug effects directly related to the amount of drugs that they're taking and the frequency that they are taking them at. And we're going to go into a little more of this. On your older adults, you need to remember that you want to start your doses low and increase them slow. So that's what it means here when it says start low and go slow. Okay? That's the policy we want to use on our older adults. Physiological changes in aging make drug therapy more complex and challenging due to changes in absorption, which can be affected by an increase in the gastric pH, okay, decrease in motility, or a decrease in the blood flow to the gastric area. Okay, distribution can be affected by the amount of body water, adipose tissue, albumin level, and cardiac output that the patient is having. The metabolism is affected by a decreased liver size and activity, which increases your plasma concentrations of the drugs. Okay, this is where you're going to see drug toxicity. Excretion is affected because of decreased renal blood flow and glomerular filtration rate, which decreases your creatinine clearance and slows the excretion time of your meds. All of this can lead to drug reactions that have a more dramatic effect and take longer to correct. So the policy in the older adult, like I said before, is to start low and to go slow. And on this slide, I have shown you how they can figure the creatinine clearance for men and women. Okay, just from the information that you can get out of your patient's chart. Okay, changes in the kidney are something that you need to be really mindful of in your older adult. Medication assessment and health teaching. The older adults also make errors in their self-administration, or they do not adhere to the medical regime for some reason, or they simply just forget to take their medications, okay? It can lead them to taking the meds too often, not often enough, too much at one time. A lot of times these patients have a fear of dependency, or the cost of the medication may cause them to stop taking those meds sooner than they need to. You know, say they are on antibiotics, the cost of that antibiotic, maybe they take 3 or 4, they get to feeling better, so they quit taking it in case they need it later. Okay? They can also become non-compliant because of the side effects of some of these drugs. They just don't like the way it makes them feel, or they get nauseous, or, you know, some of them, like, that are on diuretics, they'll quit taking the diuretics, or they won't take them as the doctor ordered close to bedtime because they don't want to get up all night and pee. Okay? You need to teach that patient to never take any leftover medications from previous illnesses, or to borrow any from anyone else. Okay? You need to use the Beers criteria to screen for any medication-related risk in the older adults with chronic health problems. And you can find this by Googling it. Okay? It is a very extensive list of medications that have adverse reactions and that interact with each other. It's going to help you reduce drug-related risk factors for the patients, and medication reviews should be done every 6 months or more often with exacerbation of chronic illnesses, okay? You need to advocate for the patient with the physician and try to get the medications that they're on down to as few number a day as possible. So if the patient is ordered to have diuretics twice a day, ask the doctor if you might possibly change the dosage or change the type of diuretic, and then take it 1 time a day during the morning, if that's possible. Okay? This will help with their compliance and help them with if they're having trouble with memory. Okay? Mental and behavioral health problems. Some cognitive changes are related to function rather than to intellectual problems, like a decrease in reaction time or impaired memory for recent events. Okay? Severe cognitive impairment, depression, hallucinations, and delusions are not common just because of old age. A patient is clinically competent if they are legally competent and they can make clinical decisions. Now, to determine if the patient is able to make these clinical decisions, you need to determine if they have the ability to identify the problems that are going on, recognize options that you've given them to take for this, make decisions about them, and provide a rationale to support their decisions that they make. Okay? A lot of older patients you will see will have an increased risk for cognitive health problems, such as 3 Ds. You need to know the 3 Ds, your depression, delirium, and dementia. As older adults age, they are at increased risk for severe mental health problems, like your 3 Ds. Okay? We're going to look at each one of these individually. Depression is the most common problem among older adults, and it can be cognitive, affective, or physical in its manifestations. Primary depression is formed by a lack of norepinephrine or serotonin in the brain. And your secondary is considered situational, and it can be caused by sudden changes in their person's life, okay? Without diagnosis and treatment, depression can result in worsening in their medical conditions, in their physical illness, in alcohol or drug abuse, increase in pain and disability. It can delay recovery, and it can cause suicide. Okay? SSRIs are the drug of choice for these patients, and the thing to remember about it is that it can take 2 to 3 weeks for them to start working. Okay? Tricyclic antidepressants should not be given to older adults because they have that anticholinergic properties to them, and it can cause acute confusion, severe constipation, and urinary incontinence in these patients. Okay? Dementia is a syndrome that involves a slow progressive cognitive decline. It is globular impairment of intellectual function, and the most common seen is Alzheimer's, and the second most common is multi-infarct dementia, which results from vascular diseases. Okay? And then you have delirium, which is an acute state of confusion that's usually short-term and reversible within 3 weeks or less. All right? It occurs in about half of your older adults who are hospitalized. Often it's experienced by people when they get into unfamiliar settings, and it can involve physical manifestations as well. Okay? They can be classified as hyper or hypoactive, mixed, or unclassifiable. In your hyperactive delirium, these patients are going to be trying to climb out of bed, they're going to be agitated, they're going to be aggressive, and they're going to be restless. Your hypoactive delirium, you're going to see the patient is very quiet, they're apathetic, and they can be withdrawn. They're acutely confused patients, and they're at high risk for functional decline and falls and incontinence when they are sent home in a delirium state. Okay? You need to collaborate with the team members to remove or treat any risk or causative factors for the confusion. You need to use a calm, quiet voice and frequently reorient your patient to help prevent and manage their delirium. The most difficult challenge is caring for a patient who is experiencing both delirium and dementia at the same time. Okay? Alcohol use and abuse. It causes an increased risk for falls and other accidents. It affects their mood and their cognitive abilities. It can lead to complications and chronic diseases like your diabetes, your hypertension, your GERD. It can lead the patient to experience isolation and depression and delirium. The NIAAA, which stands for the National Institute of Alcohol Abuse and Alcoholism, recommends, like I told you earlier, no more than 1 drink per day or 7 drinks per week for a patient that is over 65 years of age. And then I've given you the web address for the NIAAA here as well for more information if you want it. Elder neglect and abuse is where we're going next. It's a serious problem that affects an estimated 2 million older adults each year. In neglect, the caregiver what you may see is them refusing to let nursing assistants or home health nurses into their home. Neglect accounts for almost half of all cases of actual elder abuse that is seen. When assessing the patient for physical abuse, you're going to want to make sure that you assess the bathing suit zone, which is your abdomen, buttocks, genitalia area, and your upper thighs. Okay? And this is a physical force that causes a body injury. Neglect can be manifested in the patient, let me back up a minute and tell you, by pressure ulcers, contractures, dehydration, malnutrition, urine burns, excessive body odor, and listlessness. Okay? Sedating the older adults is also considered abusive. Mismanagement of their property is more common than physical abuse, and this is your financial, and it's either a mismanagement or a misuse of their personal property or resources like money, their house, other things like that. Even something as small and insignificant as hand lotion can be classified as financial abuse or mismanagement of their property. You need to carefully assess your patient for signs of abuse like bruising in clusters or regular patterns, burns, unusual hair loss, multiple injuries, especially fractures. If it's physical abuse or neglect that is suspected and you are out in the community setting, you need to notify the local APS agency, Adult Protective Services Agency. If you're in the hospital or in the long-term care setting, the person that you would notify would be your social worker or case manager, and they usually report it to the appropriate agencies. When you're in a nursing home, most nursing homes have policy and procedure that you report it to the administrator as well as the social worker and to the DON. Okay? Issues in the hospital and long-term care for the older adults. Here are some issues that they have problems with, like their sleeping, nutritional issues, continence, confusion, falls, restraints, skin breakdown, and care transitions. And I'm going to talk about each one of these individually. Sleep disturbance and disorders are common in a hospitalized patient. Adequate sleep is important for their healing, their physical and their mental functioning. So you need to keep your conversations outside the patient's room to a minimum. The environmental noise needs to be kept down, and lighting needs to be at a comfortable level for the patient to enhance their sleep hygiene. Space care for the patient to receive adequate sleep if possible, and you need to cluster their activities. So if they have dressing changes and medications and vital signs, try to get them all grouped and done at the same time if at all possible, and then let your patient have long periods of rest. Malnutrition is common among your older adults and is associated with poor clinical outcomes. You need to nutritionally screen these patients. Standard protocols should be implemented so that you perform a nutritional screening on the first day. That nutritional screening should also include their height, weight, and their BMI. Make sure to include their cultural preferences if at all possible. Allow the family to bring in foods that the patient likes if it is allowed by their prescribed diet. Continence is an issue that can be caused by many factors like acute or chronic diseases, their ADL abilities, and available staff. You need to assess the patient and identify if there are any possible causes of incontinence and fix these. Incontinence is not a normal problem with aging, but it's very common in your hospital settings and your long-term care. You need to place your patient on a bowel and bladder training or schedule, okay? And this can be delegated to your patient care techs as long as you supervise them, okay? Acute and chronic confusion affects many patients in the hospital and long-term care setting. You need to make sure that you help this patient by reorienting them to reality as much as they need, okay? The most common accidents in the hospital and long-term care setting is a fall. The Joint Commission's National Patient Safety Goal required that all inpatient hospital settings have admission and daily fall risk assessment tools, and that a fall reduction program be used on all patients that are at high risk, okay? Chart 2.4 or 2-4 lists some of the common risk factors that should be assessed and evidence-based collaboration interventions for preventing falls in the high-risk patient. Like I said before, be aware that a patient that has a high risk for falls or has had a history of falls is at a higher risk for falls, and most common causes of incidents of falls in the hospital and long-term care settings are toileting issues. Okay, so that is going to be followed by your restraint devices, not only devices but also drugs. Okay, that prevent them from moving freely. The Joint Commission has specific standards that limit the use of physical restraints in a hospital and long-term care setting. You can prevent some of these issues and needing for restraints by asking the family to stay with the patient, keeping that patient closer to the nurse's station, and other activities such as reorienting them as often as you possibly can. Okay. If all else fails and they don't work, then the patient might need to be restrained. If they are, remember it's required that you use the least restrictive restraint on the patient, that they be checked every 30 minutes and released every 2 hours for turning, repositioning, and toileting. You need to follow the facility's policies and procedures on the use of restraints, and you need to follow the manufacturer's recommendations on applications of restraints, so these are done properly. Chemical restraints are often overused in your hospital setting. Long-term care settings are more closely monitored for chemical restraint use. Common medications that you're going to see used as chemical restraints are antipsychotics, anti-anxieties, antidepressants, and sedative hypnotics. Of these drugs, the most potent are your antipsychotics like Haldol and Navine, and they should only be used on patients that have behavioral problems like delusions, acute psychoses, or schizophrenia. Skin breakdown, especially pressure ulcers, are a major tissue integrity problem among your older adults in the hospital and long-term care setting. The Joint Commission requires all agencies to have a program in place to prevent pressure ulcers that focuses on your nutritional support, avoidance of friction and shearing injuries, repositioning and support, increasing mobility and activity levels, and maintaining clean, dry skin. All agencies use an assessment tool like the Braden scale. You need to assess the skin every 8 hours for reddened areas that do not blanch. You need to supervise your patient care techs to ensure that the frequent turning and repositioning is happening, especially in your immobile patients. Skin tears are common in older adults, especially the old, and those who have who have used chronic steroid therapy. Okay, you need to teach your patient care techs to be extremely cautious when they are handling these patients to prevent tears and bruising because of the fragility of the capillary network. Nurses must communicate effectively to prepare the patients for discharge. If you are transitioning a patient and it's not going smooth, good information exchange to the older patients tends to be poor, and their readmission rate to the hospital or trips to the ER or physician's office are going to go up. Care must be coordinated among healthcare professionals. Monitor the patient and the family to ensure that they are not experiencing increased confusion about the care that they're going to need and the recommendations that you're making. It may be that you need to call the family or the patient for follow-up to ensure that your discharge instructions were clear and clarified, and that you might need to clarify any misunderstandings about medications or treatments with these patients. Patient might also benefit from a health coach to ensure that they have understanding of the care procedures and follow-up appointments that they have made for them. The nurse discharging the patient is responsible to provide the family or the facility that is receiving the patient clear and concise information about the patient's condition, their family concerns, medications and treatments, and any follow-up care that's needed. This continuity of care between the settings is essential to achieve the positive outcomes for the older adults, okay? And this is the conclusion of our growth and development. If you have any questions or concerns, please feel free to contact me at my office or send me a text on my cell phone or call my cell phone, and I will be glad to help you as much as possible. Thank you.